project, we hope. Today we're gonna get down into some of the real nitty-gritty today. So we thank you for participating all along, and if you're joining us for the first time today, thank you. And we, to the people on the phone, we sent you some materials via email, so you should have some of the materials that we're going to be talking about in today's meeting to make it a little easier for us all to see what we're covering. So, so glad to have you here. We're going to go around the room and introduce ourselves so everybody knows who's here, and then we'll go around on the phone and sort of I'll do sort of a roll call of the people that we think are on the phone. So starting to my right.
Hi, good morning. This is Jill Sparrow. Good morning. It's Eden Rosales.
Denise Peach.
Daisy Absalom.
Lois Soames. Sheila Hambury from Bayview Adult Day Health in San Francisco.
I'm Gladys Lazaro from Health.
And Lynn Benjamin, CBAS branch.
And as always, our techie guy in the back of the room, Adam Smith, is running the controls. So on the phone, let's see if we know who's out there. Is Sabrina Younger there?
Yes, I'm here.
Great. Okay, we've got everybody's mics open, by the way. It's a fairly small group today. We managed to schedule this meeting during budget hearings and all sorts of other busy things, so I think it's going to be a pretty small group. But we do have all of your mics open, and you can put them on mute. Okay, so put them on mute when you're not talking. Okay, so Mark Fuller.
Yeah, I'm here.
Hi, Mark. Deb Toes.
Hi. Hi, everybody.
Deb Toes from Anthem. We're going to have you there in a minute. Selena Escobar from HealthNet.
I'm here.
Marty Magata from Hello.
Hi, yes, I'm here.
Hi, great. And Kathy Osborne from Hello.
Yes, I'm here too.
Great. Rebecca Shoup from DHCS. Randy Cosgrove from LA Care. Okay, and Luba Droz from MLS Park.
Yes, I'm here. Good morning.
Okay, fantastic. We have a few others that we think are going to be joining us that have signed up but aren't quite there yet. Yeah. Yeah, that was just kind of bad echo. Everybody who's on the phone, put your phones on mute when you're not speaking, and if you have cell phones that are close to whatever it is that device that you're using, if you can turn those off, that would be helpful too. Okay, let us know via text. We've got we're staffing the laptops to get your comments as they come in. We'd love to hear from you verbally on the phone if you can weigh in and give us feedback. But otherwise, type something in if you're shy or you can't make it work, and we'll get to you that way. We'll stop periodically and share your thoughts. So again, thank you all for being here. Objectives for today, just quickly. We have given you a draft of what is sort of the outline for what the written narratives that will look like for this and we have given you a table with some measures that we discussed last time, quality and some possible very spend the bulk of our day. We'll have we're going to try to shut that down so everybody can hear. Okay, we got it. So thank you. So so our objective for today is to get through that that matrix of activities and ideas, because by the time we get to our June meeting, we really want to be presenting a draft. Actually, we want to share it with you before we get to the meeting and finalize within this group our strategy by the next meeting in June. So we're bringing this thing home today after 4 meetings. It's, we're all getting a little weary and want to get this thing wrapped up. And plus, I think we've done a ton of groundwork, and we've got a good product. So we're heading towards that. And then after the June meeting, what we will do is we are going to share it more broadly with all stakeholders and invite, and we'll post it on our website, and we'll invite any additional comments that anybody has from the field, and make any adjustments as necessary from there. We'll share it back with the work group, probably by an email, and maybe have more conversation if there's anything significant that comes down. And but we don't expect to meet with the work group again after June. What we do expect to do, though, is to, and we're going to talk about this today, form an advisory group a coalition of the willing who will be advisory, not having formal meetings like we've been having, but who will continue on helping us with the implementation of this strategy going forward. So we're going to talk about that a little bit today. So if you're like feeling the spirit move you today about wanting to volunteer and continue to be involved, we'll be looking to you for some of that help. Okay, so that's kind of what we have on our game plan for today. And then, of course, we have lunch. Whether we say 12:30, we're going to adjourn for lunch, and we'll have the next work group coming in for the afternoon. So we'll have a nice little social time and chatting and sort of handoff. And anybody who's staying on, we'll have IPC in the afternoon. All right, so that's the whole agenda. Any questions so far? Any objections? Okay, hearing none. We go on. Okay, so let's do a quick review of the. Yeah, Jill, I think we're going to bring up the agenda.
You want this?
Yeah, so we'll bring up the agenda, and then we're going to go to our action items, if we can find those and put those on the screen. And so we'll make sure that in keeping ourselves honest about what we said we would do at our last meeting, we will go ahead and take a look at some of the action items, some of them completed, some of them still in progress. So running down the list.
Would be helpful to turn that light.
Yeah, let's turn that light off if it doesn't make anything too sleepy. How's that work? Okay. Great. Sure. Yeah. Let's go through the action items, and yeah, you want to go through them? Yeah, that'd be great.
Sure. So we have posted the DHCS All Plan Letter, APL 15023, on the CBAS Facility Site Review Tool, and I assume that that's being implemented at this point from the managed care plans of the CBAS centers. The health risk assessment discussion and its relationship to CBAS quality strategy. We have had discussions about the managed care plan's health risk assessments, and we feel that that discussion has been completed, and we've incorporated some of what we view as health risk factors into our IPC revision, Box 17. Develop draft quality strategy report. This has been in progress since the beginning, and we're still working on it. And today we feel we've got a draft that's close to it's still a draft form, but it is close to being finalized, hopefully by June. Complete the draft quality strategy work tool. We have combined the work tool and into the report framework, which you'll see later in the meeting. Obtain DHCS data on the percent of CBAS participants in Cal MediConnect and manage long-term services and supports. We have requested that data from DHCS, and we hope that it will be available in the near term. Update work group on California Association for Adult Day Services, CADS, the National Adult Day Services Association, NADSTA, quality activities. We are going to hear from one of the CBAS providers, Diane Cooper-Puckett, later in the meeting about what CADS is doing specific to quality measures. We've got 13 here. Finalized recommendations for EQRO/HASAG focus study for CBAS. This study is on hold at this point. We're waiting for DHCS to analyze the HEDIS data that they are receiving that we hope will be available in June 2016. I know Sabrina's on the call, Sabrina Younger from the DHCS Medicare Managed Care Quality Division. Sabrina, is there anything you want to say specific to the HASAG?
No, I have that item also on our action item list, and hopefully we should have the HEDIS information by June, at the latest July. And once we get that, we're hoping to actually have it before the last meeting to share.
So if I could just, for the group, for people who come new to this discussion, the Department of Healthcare Services has identified their, what they call their, it's the ECRO, help me out Sabrina if I get it wrong, the organization that does research on HEDIS data, and it works as the, tell me what ECRO means again, it's EQRO. Sabrina, are you there? Okay.
Hello? Can
Yeah. Are you there? What does ECRO stand for? I can never remember. Do you know? Okay. All right, we can't hear you. So at any rate, they have an organization that acts as an independent sort of auditor that looks at the HEDIS data and does analysis. And there's a certain amount of dollars allocated each year for
Hello?
the organization to do
Can you hear me?
analysis of different programs. And so CBAS has been identified as one that will get some of this research allocated.
Sabrina.
Hello, Sabrina.
Oh, I'm sorry. I don't know what's going on my microphone, but it's the external quality review.
External review organization. Thank you.
Yes.
And thank you. I appreciate it. So,
No
so anyway, I'm just giving a little bit of background on this. So we are identified as a program that's going to get some of these dollars allocated for a research project. And so once we get the HEDIS data that they have been waiting on, we will be talking with the HCS about how to form this study so that we can look at some things like the characteristics of the CBAS population and possible outcomes that we can start drawing some correlation to some of the things that the providers are doing to some of the positive outcomes that we hope that the beneficiaries are having. So getting more into this measurement arena with our CBAS participants. Okay.
What does HEDIS stand for?
This is health.
Health Effective Data Information Set.
Yay, thank you, Gladys. So it's all the measures that the plans are collecting, that healthcare providers in general collect, and the plans report regularly to the Department of Healthcare Services for their members.
Okay.
Okay, moving on,
Great,
Lynn.
thanks, Denise. Discuss core quality measures at future meetings, and that's today. We'll be talking about what we view to be the kind of CBAS-specific quality measures that we're going to look at in our 5-year plan. Research what adult day healthcare centers and other states are doing related to quality. This had come up in a previous meeting, and we haven't done anything with it, so we were just going to revisit it today. And I think that Amanda Sillers was talking about doing some research on this, and Lydia's not here to see what Kaz has done, so we're just going to put this on hold till we have some more data.
But just for reference, though, if anybody wants to go to those links, there's some really great stuff, and I think it will inform us here at CDA. We're going to be talking about this today, and actually, I might want to pop some of these links later on. So let's keep this on the desktop because one of the things I'm going to be talking to you about is the information that CDA is going to be sharing as part of our transparency efforts as part of this quality project. So, so if you go to any of those links, you can find some really great information nationally and at the state levels. They link to state level data on nursing home performance, and this is some of it is what we envision for putting up for our CBAS providers and making available to the general public and anybody who wants to see demographic information about the centers, just like they have on the nursing facilities, and then so name, address, phone numbers, types of populations served, license capacity, current utilization, as in average daily attendance. But then we want to expand that out and get into some more information that may be correlating with quality, some things like, or things that consumers want. So extended hours of service, for example, additional programs beyond ADHD, CBAS, adult day programs. Beyond that, things that we're going to talk about today that have to do with proxies for quality, things like the percentage of time that you have providing therapy services in the month by your professional staff versus the non-professional staff. So there's a number of things that we want to sort of get people thinking about and interested in, and it certainly is going to guide our process as we go forward with developing our website program. So, and then the next one. These are all, we don't actually have 19 outstanding items, just so you know we've got them misnumbered.
I know.
Yeah.
I don't know what happened.
There was a larger list that we culled down. So.
Okay, so that's the Nursing Home Compare information. And then the Impact Act, Lydia brought that up at the last meeting, was asking if DHCS might be looking at what's required at the federal level of long-term care facilities, home health care agencies, inpatient rehab facilities, and I'm just going to, and these are links to, this is a link to the federal CMS website that describes the Impact Act. And Sabrina Younger, you're welcome to make a comment, but she had let me know that DHCS is not tracking this because it is Medicare specific.
Yeah, unfortunately this does not follow under MCQMD because we oversee Medicaid, not Medicare. And I'm not sure if this would maybe fall under long-term care.
Okay.
Possibly.
So while I work on this one.
Just the descriptor, the overview of what the impact is, it requires, among other significant activities, the reporting of standardized patient assessment data with regard to quality measures, resource use, and other measures. It further specifies that data elements be standardized and interoperable so as to allow for the exchange of such data among post-acute care providers and other providers, and the use of such providers of data that's been exchanged. So it's something that we can look at because the quality measures that they're looking at may have relevance to what we're looking at. So I think it's one of those bucket lists,
right? Exactly.
That we will keep an eye on to see what they uncover. Yeah. Okay, so insert edits into existing quality report. We've completed this, and all of this will be addressed in our discussion today. The next. Regulatory practices, best practices, person-centered planning. We've tried to incorporate all of that into our quality strategy report. You'll see that today. Update CBAS program description on CBAS website. Diane Cooper-Puckett has raised this issue, feeling that it isn't very user-friendly and doesn't give a good description of the program. So she had volunteered to work on that, and it's one of our future items after the work group meetings are done. There was a request to extend the PCR submission date from the 10th to the 31st, and that's been completed.
Yeah, it was already done. That's the participant characteristics report that the centers sent in to us. I think originally we had expected that we would have it on the same timeline as our monthly reports being done due by the 10th, and there was no reason to do that, so we extended it out to the end of the month for the reporting period. So that's been done.
And this is a crossover issue. The next one, develop instructions, guidance, including definitions of terms. When we're talking about terms in the IPC, and there will be instructions related to the IPC revision. And I'm trying to remember why this came up in our work group, but we have identified some overlapping issues. And I think in terms of quality, we want to make sure that terms are clearly defined wherever we can.
And for quality reporting, because on our participant data that we get from the centers, we want to make sure that they're clear about what it is we're asking for. So it has to do with just making sure that we get the integrity of the data that we're trying to go after, so further clarifying the terms.
Okay. Distribute quality initiative and measures for feedback before next meeting. We really didn't distribute it as widely.
we did it last night.
We did it last night and today.
And this morning to all of you.
So we apologize for that, but we're all running a bit behind. But after today, we will definitely, today we'll get your feedback, and we will take feedback after this meeting, between now and the next meeting, and make sure that your voices are heard. And determine the April and June meeting dates, obviously today, and then we did decide on June 22nd, it's another Wednesday, and that is to be our last meeting of this group. And then we'll talk today about forming an advisory group for both the quality work group and the IPC revision to oversee implementation and provide advice as we go forward.
Okay, Lynn, thank you very much. So let's do this before we leave this sheet. Next up on the agenda, we're actually going to start digging into the quality activities and measures that we've drafted and discussing those. But we wanted to have a sort of lead into that from CADS, from Lydia and Diane, Diane's running a little bit late this morning, so maybe we can see if we can buy a little time, and we'll take some other things ahead of that, because we really still want her to fill us in on some of the activities that that are already underway with the CAS Workgroup on quality, because they've done a lot of work. They've produced some documents that have helped inform this process that we're in, and we want to work as complementary a process as possible. I think that overall, I would say that the CADS group is more ambitious than we are with regards to finding participant outcome data, collecting participant outcome data, and tracking it. I think we're focusing more on activities that will and data collection efforts that are sort of already underway that won't put additional burdens on providers, but that are going to change the way that we work with data we currently have and making it more available and changing some of the activities that we currently do. So, so their focus is slightly different, but we do have overlapping areas, and I'm going to point that out today when we go through our activities and measures matrix that we share with you. So, but until Diane gets here, we won't be able to hear from them as to some specifics. So right now, if we could, because I think that it'll be a good setup for some of the discussion that we're going to have. Let's look at the nursing home links there on this it's on this document. Yeah, if you just scroll up, not there. Yeah, there you go. And let's just click on the first one and see where it takes us. So again, I'm not sure who you thought it was, Lydia. I thought it was Gretchen from LA Care who brought this up last time. I'm not sure, but
Lydia brought up impact,
right?
And part of Gretchen brought up the other.
Part of what we're sort of challenged with in developing this quality strategy is the context of other efforts that are underway. So DHCS has the managed care plan quality strategy. They have an overall quality strategy, and then they have plans for quality that the plans have to create. And QI, I know, Gladys, you're part of the QI at HealthNet, that internally that you all have to do as far as quality measures that all the plans are expected to put in place, and quality improvement efforts. So there's also national things that are going on with the National Quality Forum, NCQF, all of these entities, NADSAT, the National Association for Adult Day Services, are working on coming up with measures, and in particular for us, coming up with measures of quality in long-term services and supports. So in our community-based services arena, we don't have real clear measures like we do in hospitals with returns within 30 days, readmissions, and you know, so tracking emergency department visits and hospitalizations and readmissions and or for the plans tracking some of that HEDIS data with diabetes checks being done and med reconciliation being done, and those kinds of things lend themselves to more of our sort of institutional or outpatient traditional kinds of settings as opposed to a CBAS setting or adult day setting. And so there's lots of things going on nationally to arrive at some of these measures. And in fact, as we speak today, the National Quality Forum, National Quality Partners are meeting today, right now, and we can tweet topics if we'd like. There's a tweet chat. They're going on right now. They're having a conversation nationally about this very subject, and yeah, I just thought it was kind of interesting sort of points just as a sidebar. National Quality Forum has been going on for some time. What's the most important aspect of care delivery that your organization currently measures to assess quality? It's like these are the things that they want people to be thinking about and talking about, because they're trying to do what we've done here with taking this universe of ideas and sort of narrow it down to what can we start all working on to advance quality and to demonstrate quality in this setting. How are quality measures integrated into staff performance evaluations, and to whom do they apply? Leaders, nurses, chaplains. What do individuals and their families see as the most important marker of quality? So there we go to the participant and caregiver's experience of care. So in CBAS, we've never had a mandate for a satisfaction survey. I think a number of providers have done it for a long time as sort of a sort of best practice or routine, and I think that we see there's a need to maybe standardize that and make that part of our feedback mechanism, collecting data from the people we serve. How about that? What an idea. So what's the most important thing to them? If you could identify one measure to capture overall health quality, what would it be? If you could add one policy that would improve the delivery of care, what would it be? So these are the subjects that they're talking about nationally. So our conversation that we've been having here for the last 4 meetings has been focused on CBAS, but mindful of all of these other things that are happening statewide and nationwide in other areas. So we're trying to do things that are they're going to be in agreement and not out of step with the other efforts. So anyways, that's a bunch of setup. So one of the things that that we have sort of identified as an activity, we, the Department of Aging, for some time actually, in the original negotiations with CMS over this 1115 waiver, was that we would have a plan for monitoring and oversight of the program that would ensure integrity of the program, and it would include various things. And one of the areas we just refer to as transparency. So transparency being what are the providers doing? What does the provider's performance look like? What are CBA's activities around ensuring compliance with the program rules? What do those look like? What happens as a result of our reviews? How many deficiencies do providers have? What's the nature of those deficiencies? Those kinds of things. So this is what we're looking at here on this screen. Medicare Nursing Home Compare. It's a great website that talks about nursing homes around the country. So if you look at the left tab there, we have what is Nursing Home Compare. So it talks about what's on the site. What information can I get about nursing homes? 5-star quality ratings. We've talked about a star rating in CBAS. I don't think we're there unless we have like a huge movement among the work groups members today. I don't think this is the direction we're going, but there is such a thing as a 5-star rating in nursing facilities. I think that the jury's out. Some people think that it's a great way of categorizing quality, and others think it's not so good. It has lots of shortcomings. So at any rate, there's some information here about that. But nursing homes do have the quality ratings, just like hospitals and health plans do as well. Coming down the list, how do we calculate ratings, strengths and limitations. So there's a bunch of narrative on all these sites. Inspections and complaints. You keep going down the tab. Staffing, quality measures. So again, I think that a number of these areas are going to overlap. You're going to hear us talking. CADS is talking about it. NADS is talking about it. We're talking about it. What are the measures around staffing, for instance, that speak to quality and performance in the centers? So there's a lot of information up on this website. I think the thing that I wanted to show you most to just profile, you know where it is, Lynn? The one that I want to.
I think it was where we
to resources. So it'll take us out from here to the state level data, and
we want to get.
I'm not sure where it is, but we saw.
I remember it was resources, and then we had the state.
Oh, state agency. There you go. State survey agency. Yeah. So this is actually the backdoor in the DHCS's website. Actually, Department of Public Health's website. And it should bring up a picture of profiles for nursing facilities in California.
We have to plug in a zip code.
Okay, yeah, so we plug in a zip code, if it'll ever get us there, and it'll show you the profile that I was
Oh yes, go down to California. So go down, keep going. Okay, here.
So this is where we're hoping to go. If you can look at SNF there, right at the top, skilled nursing facility, and go to search. And skilled nursing facility, great, that's fine. Keep going down to the bottom, and it'll just say zip code. Let's just go 95819 or whatever we are in. Sacramento.
That's right.
Yeah, and so this will show you a picture again of what it is. Well, it shows you a map. So if you go to one of the nursing facilities that's on this list in the 95819 zip code, you can see Sherwood Healthcare Center, and other names that they're known by, Sherwood Healthcare Center. It's over here on Elvis Boulevard in Sacramento. There's their basic information. So we have this right now on the CBA website for our CBAS centers. There's a big listing of centers by name. You can sort it by county, city. You can do various things to find who's where in the state. But then when you scroll down, you get a bunch of additional information, licensee information, which we also have on our CDA website, a giant spreadsheet that has all of the owners behind the corporations, you name it, everybody's out there in public view for who's involved in ADHCs and CBAS around the state. So we have that, but again, it's on a spreadsheet. It doesn't quite look like this by center. But then when you start going down, here it tells you about, well, go back up, I'm sorry, Keith. So if you go back up, so I hope I'm not making anybody dizzy here. So license type, it's a profit corporation. There's their license number, their status is active. This was the date, the effective date of their license. This is the total bed capacity. It's a 62-bed facility over there on Elvis, and it's a skilled nursing classification. So there's information up here, and then you can also get to past survey and deficiency reports via this link. And I'm not going to try to have us find that because it'll make everybody nauseated as we scroll through. But the point is that the consumers need information, the public needs information, and we have some of that up on our CDA website now, but we're going to populate more. And many of the things that are embedded in this table that we're going to review today are things that the centers either currently report on but we don't post, or the centers we're going to be working to get them to report on, and that we're going to make available to the public. And some of them we would argue sort of proxy for quality. So it's my view that a program that offers a 6-hour program day and extended hours for drop-off and pick-up for caregivers is a program that offers more value to the community. A different kind of value, maybe not everybody needs that, but some families definitely need it. That's a good indicator of, it's a good piece of information to put out there for the public. So that kind of demographic information is pretty basic stuff. But then when we talk about things like I was mentioning about professional therapy hours, for example. So we have centers that have large operations that run programs of say 200 people a day. They're required to have 600 hours or so of therapy a month, and maybe a very, very small percentage, maybe like 2, 3, 4% of those hours come from professional staff. Now there's nothing inherently wrong with that, and the regulations allow it. But again, if I'm somebody who's looking for a facility that might have more higher touch from higher level professionals, or I have more skilled therapy needs, to know that another center has 40% of their hours that are provided by OTs, PTs, psych therapists, et cetera, that might be of greater value. So I would make the argument that it does. And it's certainly, at any rate, it's important information to share with the public. So that's the kind of information we're talking about, populating center profile screens on the website, so that's all available. And then also looking at ways of comparing providers on some of these measures. So at any rate, I just wanted to take you on a tour of that website just to give you an idea of how it looks, the information that's out there, and again, I like the map too. So we're hopeful that we can keep expanding our website out to put CBAS profile data out there a little bit more extensively. Any questions on that or thoughts? You guys like it? You hate it? Like the providers especially? Like, oh, it's a terrible idea. I don't want them to know what we're doing. No, you think it's good? Yeah. Yeah. Good. Yeah, sure.
There are other things that could go in there as well. I mean, like we're certified for music and memory, which doesn't mean, but it's just one more thing that it's another piece. So some of the more person-centered pieces, I think, could be included.
And we're going to talk about that. So let's get into it when we come to that item. But I agree. More person-centered programming, info for posting. I'm just making a note to myself. So yeah, I think that in part what what we want to do is put into this quality strategy a framework that reflects that we want to do these kinds of things. We're not going to have every little piece of it identified when we finalize this strategy, but we're going to keep adding on. This is going to be sort of a work in progress. And hey, there's Gretchen. And so what we imagine is that this is going to keep being built onto. And so when we get to that item in our table where we talk about identifying best person-centered care practices and sort of formalizing that and having that be providers who are offering or doing some of these things, again, beyond the minimum of meeting the new person-centered care planning processes and filling out the new IPC that has those in it, but actually implementing things that go sort of beyond and are person-centered. We have those identified and we sort of give providers the credit for that and have that up and reflected on our website. Yeah. And of course, all that information feeds into information that you can share with your managed care plan payers, partners too, which makes it a more compelling argument for the things you're doing. Welcome, Gretchen. Thanks for joining us.
Yeah, hi.
Gretchen from LA Care just walked in the room. Thanks for coming. Okay, so we were just wrapping up, finishing up the action items from last meeting, and we were doing a little tour of the Nursing Home Compare website. I think you might have actually mentioned that, and we have been taking a look at it. And so, just for a quick synopsis for you, we were just displaying it and talking about how here at CDA we have the objective of creating greater transparency with our data and some of the data that we're going to begin collecting through this quality strategy implementation, and putting more of that information up there for the public, and then definitely making more of that available to our plan partners. And just so for providers, because you're familiar with this, and this might be a way to help you understand this, so let's just say in the future, maybe a few years out, we have a sort of scorecard, if you will, not a 5-star rating or anything like that, but at the time that we renew your certification, so we do your on-site survey and we determine that you meet the minimum standards from compliance. But let's just say there's another checklist of 10 or so items where we say, and they give extended hours, and they do intensive person-centered care training, and they do this, and we check those things off. Those things can be information that when we send our letter back and we say, you've been renewed, and we congratulate you for meeting these additional best practice measures or something to that effect. Things that, again, sort of formalize that we have validated that you've met certain standards beyond the requirements, and then that is something that's reflected to your managed care plan partners as well. So thinking about sort of how we sort of make this information more public. There's websites, there's standard communications and whatnot. So right now we just give you kind of a bureaucratic letter. We surveyed you on such and such day, and you have the terms, and your certification is renewed, and that's about it. So there's no thank you very much or anything. So I mean, I think that we can try to work some of these measures into that, so we're communicating to everyone, we're telegraphing to everyone what the centers are doing performance-wise. Okay?
And yeah, I'm sorry I had to leave, but thank you, Gretchen, for raising the issue of looking at the Nursing Home Compare website. So that was very helpful.
Very helpful. Yeah.
Okay. I have an update also that might be important. I don't know if this is the right place to say it, but the CMS just released the MLTSS standard this week too, and it's got some interesting possible ramifications for CBAS. For instance, their interest in person-centered care. So, and critical incident reporting and certain things that we work on anyway. And so I was thinking that might be another source for us. And I brought a little summary of what they have. So.
Great. Okay. Well, let's when we get into our table here in just a few minutes, let's bring that out.
Great.
Thank you, Gretchen. Okay, and welcome Tyra Taylor from the HCS. She's joining us from Long-Term Care Division. Glad you could make it. Okay, so we're going to move on then. We're done with the discussion, going backwards and talking about what it is we have committed to do and have already accomplished. I was hoping that Diane Cooper-Puckett from the Peg Taylor Center would have been here by now so that she could report out on their quality efforts at CAD, but we'll just have her report soon as she gets here. I know she was kind of caught up on the freeway on the drive in this morning. So it set up to, let's Jill, let's pull up this document that's the really drafty framework for the strategy and then the table. And again, as set up, I think I'd like to just say that that this is, Lynn said something about a bucket list. I don't know if I'd call it a bucket list, but actually if you could scroll up to the top of the document, that would be good.
I hope.
Oh, that's no.
This is not the right one.
Yeah, bring up the whole one, this one that's,
Okay.
yeah.
Oh,
Yeah, the strategy itself.
I have this horrible feeling it's not there. So
Okay, that's okay, we'll start there.
I need to go. I'm going to go put it on now.
That's okay. That's fine. It's fine. We have it in the room and we send it to everybody. It's just it just includes sort of the framework document where we had sort of the table of contents and sort of the structure of when we really don't need it. The structure of the program, and then we're going to spend our time today on the table itself with all of the activities and measures. But I wanted to just share this. So in framing the discussion of this, at the next meeting we will have this, and we will have sent it to you beforehand. It will have narrative description that runs through some of the things that you see here. We'll have sort of an overview of why we're doing this. Okay, in short, because the feds have asked us to do this as part of our 1115 waiver requirements to develop a quality strategy, and they're very specific about some of the things they want us to do and align it with DHCS's overall managed care quality strategy. So we'll have information about why we're doing this, how we've accomplished this document and the agreements in it through this stakeholder process, what we're trying to accomplish. So there'll be some information about that. Some narrative on what are the sort of priority areas we're looking at. Again, some of them are dictated to us in the waiver that we have provider adherence to the licensure and certification requirements. That's one of the basic things that they want from us, as well as quality and implementation of CBAS participants, person-centered IPCs, person-centered care plans. So those were the two big asks that CMS had of the state in developing a quality strategy for CBAS. So you'll notice that those are reflected in our in some of our goals and objectives. So we'll have some narrative on that and some of the domains that we're going to be collecting information in and having activities in, and then we'll have some more specifics about what are our goals and objectives and who's going to be doing what and when, and then we'll have a timeline of various things that we're going to be undertaking in the way of activities and things that we're going to be going after that will demonstrate quality. So that's kind of the overall framework, and then this is the table that's at the end of that document that we're going to start. We're going to start with the end. There's again Stephen Covey there, so begin with the end in mind. So we're going to start with the end, and we'll fill in the narrative later. That's for the next meeting. But this is where the meat of the document will be. But Lynn had used the term bucket list, and again, I think bucket list has other connotations. We were talking internally about idea buckets, like places where we can put things that are great ideas, but that we have to be realistic in this plan. We have to be realistic. First of all, we're looking at this as a 5-year strategy. And 5 years may seem like an awful lot, but when we think about all of the other things that we're undertaking with regards to federal rules around home and community-based settings and new Affordable Care Act requirements for provider screening and various other things that we're doing in moving the program along each day in addition to our usual oversight activities. Adding these on strategy measures, they take time. So we want to be realistic as we say we're going to do some of these things. So part of what we're going to talk about today is timelines. But it is an evolving list. And so I guess when I think about sort of the idea bucket or bucket list or whatever we want to call it, parking lot, that we want to put ideas in this strategy so that we don't lose track of them, but we don't necessarily want to commit to doing every single last thing. But we do want this document to sort of encompass a world of possibilities for driving quality in the CBAS arena. Okay, so ideas we can put placeholders in there for them. So, and with that in mind, I just want to mention, because Diane will be talking about it when she gets here, but the quality efforts that CADS is undertaking, they have been meeting for now, I think, over a year. Working with a group of providers, and I think they have a managed care plan consultant and some other people that are at the table helping them out with arriving at what they think are some good sort of test measures to begin collecting and demonstrating quality. Everybody wants to be able to point to what's the results of this great program? What is it that you guys are doing, and what's the value that you're bringing for the dollar? So, so they've been busy working on this, and there will be a number of areas that overlap. And again, I think that they are going to be more ambitious with their sort of volunteer sites for collecting information. Staffing is a good one. I think that we acknowledge that there's a lot of value to collecting staffing data, staffing information. So if you have a center that that has, you're required to have at least one registered nurse and 2 LVNs based on your average daily attendance, but you staff instead with just RNs. Is that something that might track with better quality? I don't know, but it might be worth counting and taking a look at. So there are things like that that are, I think they're looking at in the CADS group. We might want to put a placeholder or an idea bucket item in the CBAS overall statewide strategy, but it might be a little bit more of a commitment to us to start gathering that data than some of the other things that we're going to point to. Okay, so but anyway, I'm going to reference this today as we go through this. Any questions? Somebody please say something besides me. Hello? Anybody on the phone? Any thoughts about some of the things that we've covered so far? Okay, well jump in whenever you want or type something whenever you want. So what we're going to do is walk through this table, and I'd like to, again, consider each of these items in terms of the information we put up here, because this is just draft. We shared each of these ideas at the last meeting, and we captured your feedback then. We tried to incorporate it into this format, and so, but we may have gotten it wrong, and we may have other thoughts about it than you have. Okay, so in this table, looking down the left column, we have domain. What area are we talking about? So we have several main areas that we think there are going to be quality activities that we're going to take on here. And those sort of domains or areas include oversight and compliance kinds of activities, reporting, training, staffing, person-centered care, participant and caregiver satisfaction, and best practices. Those are the areas we've sort of identified so far. Okay, so on the left column you'll see that domain. So under the category of oversight and compliance, and again, this is what many of these ideas have come from CDA, and we're vetting them through you, but not surprisingly, because oversight and compliance is our business, we have a number of items in the oversight and compliance area. So so there's other areas where we're a little thin, so we can use your feedback too. So the activities we have, that we're going to post survey reports and summary data post survey, because that was what I was just sharing with you. This is something that we've actually been required to do for some time. We haven't gotten all that up there. We have statewide aggregated data, but we don't have center level data up on our website. We share it with the managed care plans. I'm looking at Gretchen because we've been talking recently that LA Care Plan partners gave us some suggestions for improving the how shall we say, the accessibility of that information through our secure transfer site recently, and we changed that. We've got a nice spreadsheet out there for them to use, and we think that that's pretty helpful. So so we do some of that now, but we don't have it publicly posted. So so that's our #1 item there, and as a measure, you know, and again, this isn't really measured. It's just sort of like, it's more like, how do we know that it's been done? Well, the survey results are posted. Okay, so we will have accomplished that. And gotten it up on our website. So here's a very important category, and this is good that we're just on this top item, and then we'll ask Diane, who just came in, to tell us about what's happening in the CADS group in just a minute. So, but this is the way we've framed it. So our timeline, we have identified things as short-term, medium-term, long-term. Short-term is less than 2 years. Medium-term is 2 to 4 years, 2+ to 4 years, and then long-term is 4+ to 5 or beyond. So that's how we've identified everything on this schedule, and so when you look at this, each of these items, keep in mind that that we're saying in some of these that we think we can do this on a short-term basis. If it involves you as a provider or you as a plan, and you don't think it's doable on a short-term basis, by all means, raise that issue now. So when it comes to us getting getting our survey data posted. We've said that would be a medium-term goal. I think that we can do it in 2 years. I think we're probably a little bit hesitant to put too many short terms up there because we have a number of them. So we gave ourselves a medium term, and then so what I noted there in the comments is that the measure is one of many that will be added to the CDA website to increase transparency. So on this overall transparency effort, we're going to be putting more information that we already have, more information that we're going to be collecting as part of this quality strategy. We're going to be putting it up on our website and making it accessible for others to see. So this is just one more of those measures. So that's the way these tables kind of, does anybody have any thoughts on that whole discussion right there? It's pretty clear? Yeah. I think one of the things that we did, and I'll share in our conversations with LA Care, the managed care plans have had a secure transfer site that we have made available to them for some time where they can gather information on all their contracted centers. So if you're in LA Care, you're talking about hundreds of centers, right? And so they're looking at that information. We load it up every single week. And the information wasn't as helpful to them as it could have been. So we talked about ways it might be made more helpful. And so what we have done is sort of categorize things. First of all, we put it all in a spreadsheet instead of just documents that are posted alphabetically. And then we gave them information about the nature of the deficiencies. Did they fall into what would be sort of a health and safety rank, or would be sort of administrative? And so we have some amount of guidance and regulations that helps us to do this, and then we catalog things internally here at CDA to help us understand if we have a survey report that's done, a certification renewal visit, and we have 10 deficiencies. It's important to know that 8 of those were all of an administrative nature. They were things like nobody had a logbook that documented transportation time. There were things that had an administrative, they were administrative in nature, versus we found that care plans were not being implemented, and we found it to be pervasive, in 6 of 6 of our records that we reviewed. We would call those kinds of issues, if we've got the evidence, we would call that of a health and safety nature. So having those things cataloged as such helps make sense of that giant sort of report that sometimes doesn't feel very accessible to people. So we did that in our list, and that's the kind of thing we would hope to have on the sort of summary information for each of the providers as well. Okay, so that's a lot of information on that first one. It seems like a really basic one, and again, it's sort of been on our list for a long time. It is important for for driving quality and improving transparency. And so that's top of our list. Comments on that? Any thoughts on the term? Any thoughts on the yeah,
Now that you guys have been so helpful, LA Care is getting wiki. And it's one of the things, and I can share this with you, is that they're starting to realize that information would be really helpful as part of their credentialing process.
Yeah.
And so I know we've been having emails about could our system talk to your system, and I don't know yet.
Yeah.
But I do think that that would be a really great advancement if we could somehow build this data into a credentialing process so they can see when they go out to credential, or every 2 years they do that, and then they also do a site review, I think every 3 years. So just having that available would be great.
Yeah, I agree. And actually, we have. We'll just go ahead and take the next item and still let Diane catch her breath here for a minute, and because it goes kind of to this, Gretchen. This next item on our list under the domain of oversight and compliance, we have an activity there to formalize communications and collaboration with managed care plans around identifying center problems. And so, and we might want to think about how we reword that or reshape that. This is still very drafty, but the idea that we have been building our relationships with all of you for some time now, but that we recognize that we have gaps when we have issues. We have problems that we've identified. So we were saying that if we formalize that, what might it look like? Well, that we actually have internal procedures where we would have telephone case reviews when we have with an LA member. We've done that before. We haven't done it for some time, but we go out on a site review and we have really particular problems that we've identified with an individual that we actually have a procedure where we reach out to our contact person at LA Care, we schedule a conference call, we have our survey team, our nurses, whomever, on a call with the LA Care partners, the people that you identify, and we talk about that particular case. It's your member, it's somebody that we can share that information with, and so having that kind of a formal process in place we think would be of value, and then also having joint on-sites where you think that would be helpful. I know we've had that request from others. We've talked about it. We talked about it briefly with, I think, Lonnie from CalOptima, but we haven't done anything in that area. But if there's a need for a joint on-site, we've done that with other oversight agencies before, and it might be a good possibility. So we want to put some processes in place for something like that.
Yeah, I think that's great. Yeah.
Okay. Good. Any ideas around how we might shape that? Of course, we can put further information into the narrative. That would be good. We identify that as a short term, and again, I think that it's not because it's like simple to do, but it is something that we think is pretty imperative that we get moving on. Okay. Any thoughts on that? Okay, so far so good. 2 for 2, guys. There are 20 items on this list, by the way, just to give you a sense, and I think one of the cautions that came from Lydia early on was that we should be modest in our ambitions, and we recognize that 20 is not very modest. We went back through and we put some not scheduled on here after we had sort of scheduled out everything short, medium, and long term. But we only identified 3 that we really felt like we could just sort of put on the back burner because we felt like so many of these were really must-dos. So we're going to try to put as many things, try to balance it between the short term, the medium term, and the long term, so that we're not expecting that we'll get all these things rolled out in the course of 2 years. But if we look at 5 years, then it seems to be more manageable. We'll see. I won't be here in 5 years. I'll let you know. I think, yeah, check the website. Yeah. All right. Okay, so let's put this on pause for a minute and back up if we can to Diane. I had sort of given you the setup and said that that in large part, some of the activities that you guys have already sort of blazed the trail on here with your quality efforts. Some of them are overlapping with ours and they've informed ours, but if you could just sort of speak to where you guys are going with this, and that would be helpful for more context.
Sure. Lydia, you probably shared, wasn't able to be at this morning's meeting, so I talked with her yesterday. Lydia's leading this charge, but Gretchen and Lynn are both involved with it, and a lot of other CADS members. And it's one of the things that we're finding is that it truly is a challenge when you lay out a huge number of possible measures for quality to really refine down to the level of how they would be carried out, what's doable over time, and what are really core measures for quality. How do they demonstrate quality? So we have our long list. I'll just kind of flash it at you. You know, it's got all kinds of things on it here, including staffing ratios. And that's one of the things that we started drilling down into initially, was looking at staffing ratios and how they can be evaluated from program to program, and can we come up with an apples-to-apples sort of comparison that gives some sense of quality without saying that you can only have a quality program if you have exactly, you know, this kind of staffing ratio, because there are different needs in different programs. And so one of the things we learned from that is that it does take some time to do, and that it's really important to test whatever we come up with in programs to see how it plays out practically. But we were able to do that with the staffing ratios and come up with, you know, 3 different formulas for evaluating staffing that ended up with the same result. So we felt like we were on a good track with that. So that's one of the core ones that we've gotten down to a point of, as Lydia described it, fairly full-fledged. So it's still in draft form, but we are beginning to have a sense of it. The core of our indicators, it really, we kind of have to start with program meeting the requirement, but the requirement may not be very specific. And so let's say the multidisciplinary team meeting. We have a multidisciplinary team. In the regs, there is nothing that really defines that the team has to meet every day, every week, every month. And so if we check the box to say that there is a team in place and they are communicating, that can still happen in a variety of ways. And some of these measures, the program has this in place, but what really defines quality, where programs are going beyond the basic requirement or are implementing best practices, that may be what defines quality. So we're looking for, those things that should just be checked off versus what are best practices. Should the team meet at least once a month, for instance? And then you would check that box. So we continue to refine all of these, and we're going through our entire list one more time right now, hoping to get down to a point ultimately of having everything at about where the staffing is sitting, deciding what to put on the back burner, as you described, Denise, and what we think is most valuable carrying forward. So that's where we're sitting right now. We've got a meeting again on Friday.
Mm-hmm. Yeah, so I'd say, and you've been in these meetings too, Diane. We're kind of on a similar track. I'd say we've been behind where the CADS quality group is as far as really nailing down measures and getting at more specifics around best practices. But we're in similar sort of discussions around domains. So the domains that they're working in compliance, that they as basic program compliance, and again, that's the minimum stuff that that we've looked at for a long time. But compliance is obviously an important category. How well are providers meeting the basic minimum standards, and then, like we were saying, publishing that. You guys have staffing as a domain. We had staffing as a domain. You have person-centeredness, as do we. That's one of the main charters that we have for this effort. Communication, we didn't have a separate communication category, but like we have inserted there that second item there, formalizing communication and collaboration with managed care plans. That sort of falls into that same realm. Community engagement, we don't have anything in that area. Timeliness, we have a domain called reporting, and we're going to have timeliness issues there that feed in. Documentation, we don't have that as a separate domain, but it's part of the overall compliance. And then satisfaction, that's that satisfaction piece that we talked about as well. Participant outcomes, so you have participant outcomes, that's where we're getting at some of those more challenging issues around HEDIS measures, etc. But we have similar and overlapping areas, but I think that what you guys do is going to feed into what we're doing, and vice versa. And as we go with implementing, some of these are going to be written in a way that they're pretty broad, so that we can be informed by work that's happening with you and with NATSA and QF and others, and we can build them into our process.
And I would say that what might distinguish it primarily and appropriately is that the core of what we're looking at in the CADS work group is the internal functioning of the program, going from the internal to the external. So we want an effective program that's accomplishing good outcomes, high quality outcomes, and that's what we're there to do. So we really have to remain outcome focused, but at the same time we're working within a regulatory environment. We have to communicate with our partners at managed care and meet all the requirements. So going from the serving the participant at the core of it, the person-centered efforts, outward to making sure that everything's in place. That I would describe our effort as focusing on that.
Yeah, and ours too. And I think that you might be finding that some of those are easier gets. To be able to say the centers are doing this, and we can check off things on the list that we have identified as best practices. And that doesn't necessarily translate to participant outcomes, but it certainly sets the stage, right? So we're going to want to identify some of those really positive things that centers are doing and sort of give them credit for it, so to speak, and sort of publish that information to track that. Yeah, Amanda, welcome, by the way.
Thank you. Thank you.
You got here early for the IPC meeting. That's great.
Thanks.
And Ken, thanks.
What I was thinking, the neat thing about this too, that you guys are, that can be done down the line is when you just said, is that you can see down the line, we can run numbers to see if these quality outcomes actually do meet, will show in the outcomes. So the quality measures that, you're saying you check the box, we're not sure if it's going to result in quality outcomes, but we will, in a few years, we can start checking the data against it to see, this equal to this. So, and that not only are we showing this, but we're proving this makes this happen, which is exciting.
Right. It is. Lots of possibilities out there. So the first step, though, is getting a few of these measures in place, and I think that we're gonna continue to work with you guys. And thanks for inviting us along to ride along on the calls and give our 2 cents, but it's definitely informed our efforts. So is there anything else on CAT's efforts or that you want to share on the quality front, or shall we continue on?
Let's continue on.
Okay, Lynn?
We'll put that on the agenda for the June 22nd meeting to give us another update. Maybe there'll be more.
Great. Yes, we should have more.
Yeah. Okay, good. Great. Anybody on the phone? Any thoughts? Don't be shy. Has anybody typed anything in?
Didn't you say it?
Yeah.
One thing I wanted to say, because we go and actually meet with some of the center directors that we're contracted with, and the one, when I ask them about quality, they always identify staffing, and not only, it seems like the things that they're interested in is that there's a good leadership for the staffing, that the staff are well trained, and that the staff stay with them, so there's longevity in the staffing, and there's adequate staffing for the center. So I've been interested in especially around the personal care attendants or the CNAs. So one of the things I've been interested in is that what I'm hearing from the CBAS centers and what CADS is working on is kind of lining up, which is really nice, because I know our group has kind of come to the core idea, this sort of, I see it as a core value of the importance of staffing and quality.
Yeah.
So Gretchen, that just reminds me of a number of areas besides what CAD's doing that I think that we've identified here. Overlap with what you just said. I think I captured that you think that the staffing ratios are important, the quality of staffing, their training, the turnover and retention. We're not looking at any of that. I know the CADS folks have been trying to come up with a metric for that.
Right. We've had that as one of our measures, and we're going back and forth on whether to keep it in the mix or not, because some centers are just in a situation which it may be harder to retain staff because it's a more dynamic environment, work environment around them, but and larger programs too. So trying to line that up too between the larger and the smaller programs. That's another question there.
Yeah, a really neat thing about about person-centered care too is once it starts getting implemented, that there's studies that show that when person-centered care is implemented, the staff retention actually goes up. So we've got 2 measures. We've got person-centered care that we're going to start implementing in the centers, and then we've got the staff retention. So hopefully, as they're both going to go up, and they might be measures of each other as well.
So staff may be actually liking what they do better and feeling like they're working forward.
Yeah, the system includes them more in what they're doing, and they get to see the results as opposed to, going into seeing participants as work rather than seeing participants as human beings. When we can relate that it increases the retention. So that's really exciting.
And I'd say, again, in our best centers, that's already happening, and we already see that and know that to be one of those sort of hard things to the intangibles, but you know that that's what's going on.
Right.
That staff are really truly engaged, and they are already doing a lot of that person-centered stuff.
And there's studies that prove it.
Yeah.
Studies that indicate that.
Great. So the other area you mentioned, Gretchen, was leadership, and I think that we have a couple of ideas on the table here, and help flesh that out, because we agree that when you have good leadership steering, it makes all the difference. So. Okay, so let's continue on then through the list and review it, and you tell us all what y'all think. Well, first of all, not to leave this one on the communications with managed care plans too soon. We've got HealthNet in the room, we've got CalOptima and Anthem on the lines. Any further thoughts on that? I know we've been partnering really well with LA Care. They've been reaching out to us a lot, and so we have sort of formal, informal communication channels that are going. We did some work with HealthNet and with Anthem and and CalOptima, I don't know, in the early days, I guess, of the transition, we did more where we had more conversations with you all. Do you have any thoughts about how we might better sort of formalize our processes and exchange of information? Gladys from HealthNet in the room, any thoughts? Deb or Kathy, anybody, Larnie on the line?
Hi, this is Larnie. Hi. It was really nice of Jill to reach out to me because we had a disconnect when there was change of staff for my point of contact at Department of Aging. So on my end, what I'll be doing is forwarding our CAPS and our exit reports and our satisfaction survey results more frequently. And to add to it, I'll probably start sharing what our centers are doing for person-centered care implementation. They're doing a lot. I actually haven't added it to my reports, but I think after this call I'll start.
Fantastic. That's great feedback, Larnie. And I guess I'd say that I think that we've put a lot of emphasis on what information we're pushing out towards all of you, but definitely helpful that if the plans are sharing back with us information, I'd say especially important if there are significant issues going on. If things are humming along well, it's not nearly as urgent, but if there are things that are problematic, a better exchange both directions, I think we can all agree will be helpful. Thank you. I can't hear. Hello? Yeah, we can't hear whoever's trying to talk for some reason. So if you can just type in, then we can get your feedback shared. Okay. Anybody there? Yeah, too much echo. Okay, type in your comments and we'll get back to it. So yeah, we think that's a pretty important item, our continuing partnership there. Item number 3 then, and we should have these numbered because I'm referring to them by number and it's hard to see. The third group of text down under the domain oversight and compliance activity-wise provides center-based orientation for new CDA staff. So this is an issue that came up last time. We think that our staff is important, and that it is an enriching thing for them to have the experience of being with the providers before they're in compliance mode, going out there to enforce the rules. We talked about this ride-along concept at the last meeting, and several of you nodded your heads and thought it was a good idea. So you will indeed be those who we look to ask if we can send our new staff down to do ride-along with your teams, and a sort of hold harmless kind of a visit, not that they're there on any kind of a monitoring capacity, but that they're there to observe what the program is and have your staff sort of teach them about what it is they do and learn from their perspective about people they're serving, et cetera. So we think that's a pretty good idea. So the measure or the objective there would be to just develop the protocol and implement it. So obviously that requires partnering with CBAS providers to assist with this staff development, and of course, flexible in scheduling. Obviously, we wouldn't just show up on your doorstep like we do when we do surveys. We would actually arrange for you to have some time so that it worked with your calendars. So we said that that's a short-term one. We think that that's a pretty easy one to do, and I will just tell you that we have there's a lot of changing of the guard here at CDA, and so it's my goal and hope, and I think of the leadership here at CDA, that we continue to keep the culture that we have and we've had for a long time. And so as we hire a lot of new people, these two gals to my right are both within the last year, 2 managers, Eden and Jill, and we have several staff retiring. Longtime staff member Lynn Kelm is retiring, and her last day is May 1st, and so she's been here for almost 20 years now, I think, and several others. Keller will be retiring this summer. Who else is retiring? We've had some retirements, and so we're hopeful that we're going to have some new positions coming through the budget this year. So we're going to have a lot of new members, and so we're going to help you, look to you to help us to keep the traditions alive and teach them what the program's all about. So,
Selena had a
okay, Selena's comment.
piggybacking on the previous comment about exchange of information, we are moving towards electronic communication and exchange of care plans and assessments. In addition, we are developing a report card of sorts that will allow the centers to receive feedback from us on a regular basis.
Wow.
This partnership is important to us as it enhances coordination between all who touch the member CBAS participants. That's it.
That's great, Selena. Thank you for that feedback. And we would love to have a separate conference call with you and talk about what you guys are doing. Love to hear about the report card concept. We've toyed with that for years here, and through other busyness and failure for all of us to agree on what it should look like, we haven't moved it forward. So we'd like to hear about what you guys have come up with. So that's great. Thanks very much. Yeah, Diane.
Relative to the visits to the centers, it's just from the quality discussion, it's occurring to me, to work out for them to attend an MDT meeting. I think that'd be wonderful.
Okay.
Because in all these years, I'm thinking even in our reviews and everything, there's never been a chance really for the analysts to see the MDT really function together.
That is a great idea, and I can tell you that there are some of our staff who find it one of the most frustrating things in the world that we don't have in our regulations the ability to say teams must meet, because we have centers that are, we can identify that there are problems going on and they don't have functioning multidisciplinary teams. And how do you run this program without that? And so our regs basically say that there has to be team process. And the centers have to demonstrate that there's process, but they don't have to meet. And so we have staff who are endlessly frustrated by it. Clear failures because the teams aren't meeting, but there's no mandate. So it would be great to have them participate in the team process. See what those look like. That's a great idea. Okay, I got it. Shall we move on? The next one down. Reform ADHD statutes and regulations to conform with current CBAS requirements. This has been long-standing on the must-do list. The measure would be that they're done and enacted, and this is definitely a long-term project. This is a 4+. And the reason for that is we put laws and regs together. Many of you know that it's a lot easier to get laws passed, although if you've been involved in CAD's the last few efforts, you would know. So, but it's easier to get laws passed than it is to get regs done. So that really, getting the statutes reformed within 4 years is a doable thing if it's a priority, and getting regulations done is really more like a 5 to 6 year project. So truly, if there's commitment to doing it. So, but we all know, we know certainly here at CDA the challenges of having laws that are out of step with the waiver requirements, that are out of step with the regulations on the medical side or different on the licensing side, and to say nothing of the fact that we're talking only about ADHD program throughout everywhere there's no CBAS. So so there's a lot of things that need to be tackled in statutory regulatory reform. Yeah, Diane.
In the interest of time, I'll keep my comment at one word: rural.
Rural. Yeah. Thank you. Rural.
I was thinking, it seems that it would be important to have some short-term goal related to this, though, because I know I'm finding it so frustrating to have those discrepancies, and when I don't know what it is I'm supposed to be following and paying attention to, and or where I know I shouldn't be, even though it's there. And it seems like some short-term goal, just to know that it's being worked on, would be a good thing. Not, obviously the whole thing is long-term, but
I second that emotion.
Okay. So let me ask you to skip ahead, because I'm going to ask you for some ideas now that you made this suggestion, and you can be in on this too. If we skip down to, I think it's under best practices. Look at the second item under best practices. And we have that we would, and this by develop, and I think this was a CDA, implicit there, a CDA, develop user-friendly program requirement checklist job aids for centers. So now, so this is something our staff have wanted to do for a long time, and they've actually recently produced one for meds administration, or meds issues at center. Our nurses have put together. It's a long checklist. And it basically is a user-friendly distilling of regulations that we are giving out to nurses when we go on reviews and saying, this is what you should be using to self-assess whether your meds are in compliance at the center. And are we talking about things like that as short-term goals?
Yeah, actually,
okay.
that would be great.
Okay.
We just had our survey, as you probably know,
yeah.
and we got that list afterwards.
Okay.
And I actually just faxed it back to them a couple days ago.
Okay.
So it was very helpful.
Okay, good. So that
it was very helpful. Because things are so many, yeah, it was great.
Okay, so when you talk about something that might be short-term, because there is no short-term fix for statutes.
For the regs, I get that.
But if there's additional guidance that came out like that, some tools, and then it's not something that's mandated, the centers don't have to do anything with it.
Right.
But if you voluntarily sort of post it in your offices, you do it, you use it, then we're thinking of that sort of best practice.
Yep.
Okay. Okay, good. If you have any other ideas for how we might get something more short-termy that would help with you and Sheila when people are new to program director roles or new to the centers, let us know. But yeah, we recognize that for years, we've done that. I think we try not to, but I think we've done that. Well, the regs say, our 54211 says, and it's like we forget that it's not as easy for everybody to look at 54211 as it is for us.
And even though you read those regulations over and over,
yeah,
and read all of them, many times.
It's pretty dry stuff.
But well, not only that, it's like where does it fit in? And today, what I'm working on is this issue, and it may not fit in today. It fits in another day.
Yeah.
And having those more distilled would be very, very, very helpful.
Right. I think. And we've thought mostly of sort of program or discipline specific things and breaking down that. Yeah.
And that because that's such a big project, and that might be because to me I like to break everything down into measure into smaller goals. So that if this is the the long-term goal, figure out that name that, and then decide in year 1, year 2, year 3, year 4.
Right.
These are our our milestones, and perhaps coming up with these checklists or orders that would kind of be the goal would be to get there in a year, or that would be the first kind of goal, and then everything's built from that.
And that kind of sort of goes to this question of how much detail do we want in our final strategy? And my hope is that actually sort of looking to DHCS's overall quality strategy, there aren't a lot of real specifics in there. It's a general strategy, and my hope is that what we will do is we will wrap this thing up in June or shortly thereafter, after the last meeting when we've had some public comment on it, but that we have this very broad strategy from which we have the advisory committee that goes forward advising on implementation, on developing work plans for various items and helping us to get there. But yeah, I think that you're right. We need to chunk things down, and we're going to have to be a little bit flexible on the timelines for that. So maybe it took us the better part of a year to get that meds one done. So why, I'm not really sure, because it really isn't that complicated. But when it comes to all the other things that you're doing, it's hard to get a release feedback and agreement, and then get a version that's ready for print. Yeah.
Well, Tim, that's one. I think the beauty of what you're describing part is that we've got a lot of partners. So the same page, because a lot of people coming through managed care and through CBA, et cetera, are also new to the programs. But the other thing is that I think having a clear reference that tells what has superseded what is a starting point, because I think that's part of what's driving people crazy when they come in and they're reading the regs. That reg says you have to give a financial report to the CDA every year.
And what are the requirements for central agreement? Where are they?
And there have been a lot of changes, and there have been a whole lot of letters. But which letter do you look at, and how do you know when you look at it? The other thing about that I was thinking is that in those little check sheets, it would be great to actually name the discrepancies.
Okay.
They're not named. For instance, I'm just thinking, I didn't think of this as feedback about the medication. Just an example is that one of the regs says that expired meds need to be flushed down the toilet.
Right. Yeah.
Right.
Yeah.
And we all know that that's not correct.
Not the practice anymore.
That's not the practice.
Right.
And in fact, it's
we updated that though in the check sheet, did we not?
No, it's not mentioned.
Oh, it's not mentioned.
It's not mentioned, and so it should be mentioned that it should be named when there's a discrepancy. That discrepancy should be named. Like here is what this says, this says this, this is what you should be doing. Because it does talk about the disposal of beds and properly logged and all of that, but it doesn't talk about that the regs say you should be. So I think if you name those things, it would be very helpful.
Okay, that's great feedback. Thank you. That's really specific. That's helpful.
This might be getting a little bit too far ahead, but I'm thinking of the crowdsourcing, and if there's an advisory committee, instead of tasking somebody from Department of Aging to actually write out these lists, maybe people in the group, maybe different adult day care centers, adult day health care centers may want to take on, like I'll take on, a little social work part. Or, and then submit it.
It's a great idea.
And then you don't have to, you guys aren't tasked with this monster of everything. And, then you can vet it.
I love it. You are on my speed dial for
social work.
Okay, no, it's a great idea. And again, because we're going to talk about advisory committee going forward, I don't want to scare anybody by telling them that they're going to be doing a bunch of work today, But yeah, that's what we're hopeful that we can, engage people in helping with the implementation. Yeah, good. Yeah, and again, there's no reason why, and some of you guys have more experts in your programs. Diane's got some people who have been there for like 50 years, so they know what we do.
Oh, come on, it's 365.
Right, so yeah, you can certainly help all of our new rookie staff with putting these together. Okay, moving on then. It sounds like there's wild enthusiasm for that idea of reforming the statutes. Yeah, let's go back up to the top. Sorry, I have a light today.
That's okay.
Okay, so we are at revise and implement CBAS IDC. Okay, so this is already underway, as all of you know. No news flash, but we're going to definitely put this in the quality strategy because I'm going to take credit for it. And this is going to also include revising the Medi-Cal manual. And I think that the last time we met, or maybe in between, we agreed that we would write a separate set of instructions that are outside the manual that are just attached to the form, not attached to the form, but as part of the form package, so that we have a freestanding, not just in the Medi-Cal manual, set of instructions for inclusion of the IPC. So that's part of this, as is training for the managed care plans and CBAS providers on the new format. So we say that this is a short-term timeline because this will surely be done within the next 2 years. And in fact, we expect that we'll conclude our workgroup activities in June, the same day we conclude the quality group activities. From there, we will publish the draft, recommended draft from the work group up on the website and solicit any more stakeholder feedback. We'll have probably a email exchange with all the work group members about changes and feedback that we got, and if we need to, we'll call you together again, but we're hoping not to. And then from there, we hope that we're going to be putting together the training plan for the fall and an implementation date in January. So I think we've got some of our software vendors who are going to be on the call later today, and we've got a bunch of people who are going to go down and talk to them at the CADS meeting in May. Our IT people, we're going to be talking to them, and hopefully that they're going to all be on board with having that implemented by January 1. So that's imminent. That's good news. Right? Any thoughts on that? So that one's short term for obvious reasons. Nope. Nobody wants to make it slow down or anything. Okay, good. Okay, so then next we are at, we're still in oversight and compliance, and we are looking at facility uniform. Okay, yeah, there we go. Okay, so we have talked about, this is all stuff we've talked about in here. We talked about it with the IPC, with regards to the IPC as well, that there have been long-standing requirements in the law today and in the Medi-Cal manual around a history of physical being a requirement for being standardized, and actually the law says it has to be submitted with the TAR, so that's a little bit out of date in the laws. And that was supposed to be developed by the state in collaboration with the provider organization, and so that there's the reference there, Welfare Institutions 14526.1. We never reached agreement with that. Those groups, we got together and arm wrestled and disagreed with one another and walked away with something close, but and we never implemented it. So we're going to finish that. So I think that the objective here is to is to pick up as close to we can as where we left off. I think it was somewhere around in 2007. So we have some templates. I think that CADS has a version of that that we reached the impasse, and I think we're going to dust that off and take a look at all of our notes and see if something that will satisfy the need for uniformity, satisfy the regulations, and also satisfy the reality of the amount of time that it takes to complete it. I think that's where we reached the impasse. We had some of our state people wanting something that was about 5 pages long at the time, our A&I colleagues, and I think that that was really where we reached the impasse. So we're not going to get physicians to fill out that many pieces of paper. So we'll resurrect that and get that formalized. And I think standardizing that will certainly help a lot of providers that we still to this day ding because they don't do the H&Ps correctly and they don't give the right information. So it will help in a number of ways. Yeah, Diane, and then I'm sorry,
I just wanted to say that you sort of mentioned it, that physicians are important in this picture too, because they don't like to do these too much.
Yeah.
And so, some places they've tried to charge for it.
Yes.
Put that in the mix because that makes it even harder for the centers if it's too complicated.
Yes. So keeping things as minimal, but meeting the requirements and the needs for you all to get started with delivering care is important.
Yeah, just to underline that, we've had physicians say they don't refer to CBAS because they're not going to do that.
Oh, nice.
And we have a two-page.
Two-page should I send for the patients to get these?
And it's based on the CADS. We've made some changes for ourselves, but based on the CADS, and we've had people say, you want too much, we can't do that, we don't have time.
Wow.
So we won't refer people.
That's a really unfortunate thing. Yeah. It doesn't speak to the integrity of the physician.
No, it doesn't. It doesn't. Yeah. But again, because physicians are so busy right now, Medi-Cal physicians in particular, with the Affordable Care Act, and so. But you're right. We've been more than frustrated with that particular physician.
Amanda, how does this work with the manager? I'm just thinking to make it smoother, because there's been a frustration for 20 years. Now that we have managed care involved, managed care will have an HMP of all of our participants. So how
not necessarily. No. I mean, I think you're right. So I don't mean to cut you off. They don't, but there is an opportunity there maybe to leverage the help of the plan.
Or just if the plan has an HMP, allow that. I mean, maybe the regs is not a uniform HMP that has to come through, but information from the managed care company that's like it, their HMP, could count towards that requirement, which would take that whole level of frustration out of the process. If the managed care doesn't have the HMP like we need it, then here's a uniform.
Right. But you still need a doctor's order.
Yeah.
You need the doctor's request for the services.
I would think a doctor's order is fairly simple to get.
Right.
I mean, that's a signature.
Right. But we have had assistance from our managed care
from your medical director
in encouraging the doctors who prefer not to do this.
Right. Okay. Right. That's great. Gretchen, did you have a comment?
Yeah, I was just thinking it's interesting because we're actually, most of the health plans are in a delegated model situation where we delegate to the physicians. We don't necessarily, it's really the physician that actually has to complete it. It may or may not be in the health plan's hands. So we're I think we're in the same kind of leaky boat.
Right, yeah.
Yeah. So.
Okay, Diane.
Well, the question of what's an acceptable H&P, I think, comes up because you have to have gotten the H&P within the past 6 months, I think it is, to be able
90 days.
90 days, yeah, I don't do that part of things. But so it's actually the 90-day time limit is often difficult. But we have, as they're mentioning, getting the authorization, that could be fairly straightforward. Getting a recent H&P from the physician that they already have and their records of the visits, that often has all of the information in it that we're getting on the H&P anyway. We get all the hospital records, so that also contains other information that relates to the H&P. So a definition of of what an H&P has to be in order to be able to go forward with someone's services might be helpful.
Right. Right.
And what we would boil a standard form down to, such that the physicians would be able to have the time to complete it. And conservative in the future, we know they're open to get
right.
You know, that might be one place we need to start looking at.
So I'm getting mindful of the time. I really want to make it through this list, so I'm going to get you here in just a second, Ken. But just to say, anybody who has real passionate feelings about this is welcome to join the group that's going to help us finalize this H&P. So so happy to take your assistance. Yes, Adam? No? Nothing. Okay, Ken, really quick.
One point there was a discussion that probably Medicare will generate a billing code for the doctors that they can fill out and charge a minimum charge.
Right.
Probably that's one of the areas that that will encourage them to do and to do it right.
Yeah. I think that there is I think that there is something physicians can bill for paperwork, but I don't know if it's for this.
But probably not if the managed care are saying it probably needs to be easier than before.
Yeah. Okay. Outside of the realm of this discussion, but you're probably right. That if somebody got paid for it, that they might be inclined to do it. Okay, so moving along. Develop standard participation agreement form that meets regulatory and 1115 waiver requirements for person-centered planning. So this is something that's been on the hot topics list for some time. So basically, having some standard language that that ensures that that all parties understand. The providers understand that they're accountable for doing person-centered planning and needs to include certain elements, many of which are right now in the 40-year-old regulations that specify participant rights around their right to be involved in planning their own services, to be informed of their care, et cetera, et cetera. So we have an old template that we had in the provider manual many years ago, so we want to dust that off and create a new sort of standard. Providers can still put their own headers on it and add anything else in, but they have to have sort of a minimum, a number of things that are sort of clicked off during the participation agreement signing exercise. So that's been on the list for some time. Yes, no. We have that as a short term. That's a pretty easy realize. Modified participant characteristics report, this is us. So our current report to incorporate new IPC fields. So we developed a new PCR form just 3 years ago now, it seems like. It seems like a lifetime ago. There's been a lot of bumps along the way. But once we get that new IPC in place, there's going to be a whole bunch of new data collection that happens around that. That you will have to do during your assessment processes to create the new IPC, and we want to get that data out on the back end. So we want to revise and be able to publish that data as well. And that's a medium-term goal. Okay, we're blowing through these. Increased transparency, we've already talked about this, by posting more centered demographic and performance data on the CBAS website. We've identified this as a medium-term objective. And so, again, we talked about examples of center hours, population served, languages spoken, and then numerous statistics that are embedded in this quality strategy. So as we get to those items where centers are doing certain best practices and we click them off and we validated that they've done these things, then they get rolled up and posted on our website. Okay? So more transparency about what it is that you all and we are doing. Thoughts? Yeah, Gretchen.
Oh, no, Gretchen. Well, you already actually have that center profile that you guys created for all the centers with languages and all that good stuff. I mean, that seemed like that's really useful. I mean, could this one be done short term? Because you have a lot of it.
So I guess we put medium term again because we didn't want to have too many short terms and we were getting a lot of short terms. But so I guess in getting to what Amanda said earlier, in chunking these things down, pieces of it are going to roll up a piece at a time. But there's also other things that are going on internally while we're getting our CBAS portal up and running. That's what Eden does most of the time. So there's a lot of pieces to it. So yes, we're going to be sort of trickling these out a piece at a time. But yeah, we have all this information on our database right now. It's a matter of merge it and roll it up onto our website and keep the data timely. So yes, we'll get stuff up there as we can. So some of them are shorter term. Dan?
Well, my comment is my mantra about consumer friendly and making it easier for the public to access our programs.
Yes. So. Yes. Yeah. And putting a deficiency report out, how much value is that to the average person? It's not even much value to people, who really do understand these things. So being able to like create, sort of summary legends and things that will help people to understand the nature of problems if they were identified, and then definitely the information about access to services, extended hours of services, and say what that means, and things that help people understand.
Yeah, and I think putting it in the context of the core of what the program does, we've talked about this a lot, so that's why I was saying, let me just capture it in a brief moment. But I think even when we get into all this performance stuff, first people have to really understand what the program's about to even have any sense of what any of that means.
Yeah.
So I'd love to see it in that context.
I'd love to have you volunteer for that.
I think you volunteered me.
Oh, yeah, okay, great.
I can volunteer.
Okay, good. Moving on, recording. So this is a good one.
We have a question too.
Okay.
Selena says, would this include any FSR information as well?
So right now we don't, oh, wait a minute. Oh, I was thinking of PSR. So your facility site reviews, I assume she's referring to the managed care plan's facility site reviews. So we don't have any of the information on the facility site reviews that the plans are doing. So there's no reason why we couldn't look at capturing that information and making that part of the profile. So, and that, I guess, Selena and others goes to more broadly looking at how can we partner with exchanging information and have that all become part of a sort of consolidated snapshot on the profile on screen.
Yeah, and even before the consolidation, you could certainly have a link.
Yeah, or a link to it. Yeah,
and then
good point.
Chunking it out.
Good point. Okay, great suggestion. Okay, so moving on, under reporting domain, now we're in a new domain here. So track and post center adherence to CDA reporting requirements. Okay, so this is we do track it already. So we have centers who are on the chronic offenders list. I don't know what we call them, all sorts of things internally, but these are basically failures to get reports that are mandated in return to us. So we have providers that we have to call every month and be on for months afterwards to get things to us timely, get things correct. So we think that would be a valuable measure of at least organizational performance to report out on the sort of percentage of times that providers were reporting on time.
We are having a real, and I think this might be true of other health plans too, we're having a really difficult time with compliance with submission of the CLIA that has to go in as part of the credentialing application. And so I don't know if we could add that to the mix of reports that somehow get noticed and published, because it causes a lot of snarl in our credentialing process.
Right.
Yeah, where the contracting people are saying, shut this center down, they didn't meet the credentialing.
Right. Yeah.
It's really just about.
Oh, I understand. So again, as we think about this item, we can expand this out a little bit, possibly to incorporate. We're thinking specifically about our monthly statistical reports that come in every month and our customer characteristics which come in twice a year. But if we wanted to add to it that, some kind of a, measure of managed care plans complaints about late filing
credentialing documents.
Yeah, credentialing documents or something, so we can add that to the post. Okay? Or it was in the positive, timely reporting, and that's the gold star. Yeah, somebody was wanting to weigh in? Is somebody on the phones wanting to say something? Okay.
I just want to note to Gretchen that CAS is looking at doing some training on the CLIA waivers again, lab requirements.
Yeah, and we've been talking to providers about it as well.
They're just not, they don't have them.
They're just not updated,
They have to update them if they change owners, they have to update them if they change location, they have to update them every so many years. I don't know how many years, it's a licensing requirement, so it's not my area, but yeah, they're supposed to be.
So that, I think it's updating for them, but then they actually don't turn anything into us, so then we're missing that piece. So I think
all right, we got to keep this thing moving. So that's all we have under reporting. So, but we'll note that in fact I didn't do it. Did somebody else note it in my group? Reporting, so we're going to add that one.
Denise, I'm sorry, I have one more thing. We've been talking with you about the three big reporting requirements that relate to managed care. One is critical incident reporting, and we just finished some training on that. And then we started down talking about how the CBAS programs technically should be updated plan of care when there's a level of care. So someone or goes to the hospital or IPC, and then we get discharge plans when someone needs a new op. Or discharge information. And I'm wondering if there's, since this is technically a requirement for all the health plans, I'm wondering if there'd be some way we could do some work around those two areas and to get some common sense of what that means and what really should be turned into the health plans. Because we tried, but we were shooting in the dark a little bit and finally decided to pull it because we weren't quite clear we were defining it correctly. And I think that information flow would be helpful, but we want to make sure we're being consistent and asking for the right thing, I guess.
So the answer is yes. Yes, we can do some work around this. I'm making a note. So I agree. I mean, I think that this was something when we drafted the new waiver amendments to the last stakeholder process, and we had some enhanced language put into the waiver around coordination between the plans and the providers and exchange of information and clear communication pathways and lots of different languages in there. We never really regathered to revisit what does that mean? Well, what are the sort of baseline standards? I think would be a great effort. Be happy if you'd spearhead it.
And we have that spreadsheet that the IPC subcommittee developed that Gretchen facilitated. It was identified.
Right, that's a great starting
the program we should be looking.
Yeah, but getting at some sort of baseline standards of when does the provider, when should they be expected to exchange information with you about somebody's changing care, and likewise you to them if you know about it versus them.
Right.
So yeah, I think we have some work to do there, and happy to partner up there. Okay, so training. So validate all required training of center staff. So it is in the regulations right now. Certain things need to be trained to either prior to hire or within the first 6 months of hire. So basic things like orientation to job duties for anybody you hire. Elder abuse reporting training is in the requirements. HIPAA training is in the requirements. First aid and CPR have to be validated within the first 6 months. There's a number of things that have to be done within the first 6 months of hire, and then on an ongoing basis now we have new things specified in our federal waiver, things like person-centered care training, things like they have to be oriented to any specialty populations that you serve. So there's a number of things that center staff need to be trained in. Now, we know this, and I can even tell you where most of them are buried in the regs and the waiver. We have not been consistently looking at training all staff in the centers because we have just, frankly, not enough resources to do that kind of a sort of audit-like review. So we're wanting to create a process where we have all of those trainings identified on some kind of a cheat sheet or job aid, what have you, and incorporating that into our process somehow. We have a limited number of bodies and a limited number of time, but we think that perhaps we can, once developed, send back to the centers, and as part of our, what we call our pre-screening review prior to the certification renewal, we send it to the centers and we say, send this back to us with this identified for these staff members, that they can validate that things were done on certain dates, and then we can do some kind of spot check when we're on site or something to validate minimum required training that's done at the center. So we absolutely believe that training tracks with quality, lack of tracks with poor quality, and yet it's been an issue that's been hard to chase down for us. So this is what we're grappling with. Yeah, thank
you. You have email contact with all programs.
Yes.
Right? So what I would suggest is sending out annually in January the reminder of training requirements.
Yeah.
Because it's a little late when you get to the certification.
Yeah.
That would be a great administrative checklist for the job checklist.
Yes. Yeah.
I think Jill sent an email before about that. He sent an email on certain requirements.
Did you
just
I kept it in my email.
Right.
And I think that way, if anything's been added since the prior year or changed or something, it would be really helpful.
Okay, so it sounds like everybody's on board with this. It's not very controversial. It's a matter of, it is an important requirement. It's foundational, and we've been putting more information out there. We sent out an all-center letter back in October about training that needed to happen, but we think we need to get even more specific and then build it into the process so that you guys basically tell us, dates when everybody was trained and notify us that people have been trained, and then we do some kind of spot check. Or maybe even your managed care plan credentialing people can help with that too. Okay, good. No controversies there. We say that's a medium term. Training. Hello?
Yeah, this is Mark.
Hey, Mark.
Hi. Just wanted to make a comment, with this, maybe we could change the staffing report and include the staff training in it.
Wow. That's not a bad idea. So we can take we have we call it the ADHS6 form, because that's what it is, but it's our staffing services arrangement form, and maybe having sort of, I don't think anything more could fit on that form, but we could have sort of an addendum to it that has that information on it. Now,
yeah, because the report will clearly identify the new staff members and.
Oh, the new staff members, right? To ADHS6. Okay, so we'll talk further about that. I think it's a great idea. I wouldn't want to have duplication of existing staff, because that form shows everybody, but if we could find a way of identifying new staff and validating their training there, I think that's brilliant, Mark. Okay, so I flagged that. Thank you. Anybody else?
Supplemental page to that for any new staff.
Supplemental page for new staff.
Yeah.
And it has to be simple, a simple check off or simple dates on it. Form.
Yeah, my request would be that we just indicate on there that they've been oriented, and the documentation would be separate from that, because I prepare those, and it's a lot of effort to get all of that.
Yeah, we don't want duplication of record keeping, but it may actually be the record keeping that you have. I mean, if you think about it, like if we designed it in a way that an individual's sort of training could all be checked off and then put in their personnel file, that might be, one document copy.
We have that.
Yeah.
That I think has all of the things that are required that I've made up. So when a new person comes, we just go down and check off they've done these various things.
Yeah,
I've seen those incentives.
Yeah. Okay, great. Well, we'll find a way to do it as expediently as possible. Great idea. Okay, so the second one there under training, develop and adopt standardized curricula for specialized training of center staff for voluntary completion. Okay, so this goes to actually sort of a best practice thing too, so it kind of fits in both categories. So the first item we're talking about required minimum training. The second one we're talking about taking things to another level and saying if centers adopt some of these standardized training curricula and go through them, person-centered care training that goes beyond just the minimum for developing person-centered plans, et cetera. If centers do, let's just say this is one near dear to my heart, and you just mentioned it, Gretchen, administrator program director leadership training. We've talked about this over the years. We don't have a standard sort of accreditation process or credentialing process for leadership in CBAS centers, but I think it would be a fantastic thing if we could agree to all program directors and administrators who have sort of these core leadership programs that they take through the CADS workshops or through the through independent organizations that do training or any kind of other ones that we put on the sanctioned list, and then administrators or program directors take the training, and then we can give them credit for it and basically identify them as having received this core leadership training. So that's what we're talking about is in the way of specialized training. So we put that as a long-term goal. There's a lot of pieces to that, but the idea that we have the minimum level of training, and then we have providers sort of implementing best practices around additional competency training. Yeah.
And it would be really nice is because I think with what CADS wants to do probably, and of course what I would like to do is start developing these trainings. So maybe if you had a wish list of what trainings would you like to see come out first, again going back to the chunking, and put in place the protocol of that you to submit it to you and you approve it or disapprove it or whatever. I mean, that was.
Yeah, I don't think, you know, at this point, we've talked about this internally. We know that CCL, Community Care Licensing, in the past has done, you know, sort of vendorizing of trainers with certain core curriculum and everything. I don't know that we can get that fancy. We can put that on the, you know, aspirational list, as Lydia always says. That's aspirational. But something that's within our advisory group or we want minimum criteria for training for these, you know, 5 different areas: for dementia training, for person-centered care, for leadership training, for and we develop something, and we allow, you know, allow the process to unfold from there. But overnight, a formal vendorizing process.
Submit it to you. You can say, yeah.
Yeah, I don't know what it looks like, but I think that, you know, the value to having advanced level training beyond the, you know, minimal checklist upon hire is what we're talking about.
Yeah, and the really, the really awesome part of that is it goes more to the crowdsourcing. So you can actually have, you know, real specialists in dementia developing, you know, and real, so you're, you know, again, you're going out to the world to get the best.
Right. Right. Which is, yeah. Okay, so more work to be done on the concept, but that's the concept. We want to keep it in, yeah, and it's long term. Okay. Staffing item, track and post centers, professional therapy services provided. Okay, so we have one item listed under staffing. We didn't go for some of the ones that that CATS has been working on, and not for any special reason, but this one right here is a pretty easy. I'll be honest with you, that's one of the reasons why we put it here, and we think it's an important sort of indicator. So when we do our certification work, we have centers identified for us, periods of time, the numbers of hours provided by through maintenance program, by program aides, numbers of hours provided by the speech therapist, physical therapist, occupational therapist, LCSW, psych consultants, and so we know what the center is required to provide. We know the number of hours that are provided as a proportion of that are provided by professional level staff, and we think that there's some value to reflecting the amount of time provided by professional staff in a given month. So that was one staffing measure we felt like which was within our reach and something that we can make available.
And there need to be guidelines as to what those things are.
Could you speak?
Yes.
I'm just thinking there need to be guidelines as to what, again, what's the sort of standard for that. As you're saying that, I'm thinking we're not reporting that probably correctly in on our MSSP. I'm not on our MSSP.
MSSR.
Yeah.
It's not on your MSSR. Okay, so here's how it works. Really, really basically and quickly. We are, because we are running out of time. So you're required to, based on your average daily attendance, provide X number of hours of therapy services in any given month. You can meet that any number of ways based on the needs of your participants and the way that the program is structured. There's no minimum set number of hours that need to be provided by the professional staff versus the program aides that are doing maintenance program kind of therapeutic activities. So when we go out to survey, when we're preparing for that, we send you something that we call a therapy consultant and a blog or something like that, and it'll tell you to give us the number, the names of the program aides that are providing maintenance program services, the number of hours that they provided during specific months, and the names of all your professional staff and the hours that they provide. And so the math of it is that how many hours did you have, numerator, denominator, how many hours by your professional staff in total as a percentage of the number that you're required to have. So if you had, let's just say something ridiculous, but things like this happen, you have 600 hours that you're required to provide services, and you've provided 6 hours by your professional staff. 1% of your time to meet the therapy hour requirement is being provided by your professional staff. Okay, that's a program that's providing a very low level of either skilled intervention or supervision and on-site time by the professional therapist. Yeah. And,
well, I just, again, to keep it short, I think we need to study the meaning and significance of how this comes out. What Lois is saying about the standards that people are thinking are in place, because we provide 100% professional therapy hours right now, but another model of program, you know, that we get to in the percentages may be appropriately different for different kinds of programs.
Yeah.
So that's just my caveat on this. I think we need to look at, as it's starting to play out, what it's suggesting about the programs. And if there's a threshold, maybe that's the quality threshold. But above that, it may differ by model, or various things may come out of that.
Super quick, it might be great to break it down. So if you have a center that's, they call themselves a mental health center that's providing mental health services, and yet their LCSW psych hours are only about 1% versus 90% of the PTOT, you've got a disconnect. So even breaking it down would be really valuable to see.
Right. Yeah.
Yeah.
Yes.
Min Cole, a comment going back to the leadership training. SNF administrators training domains from NAB can be used as the references for leadership.
Okay.
Training for ADHD program director and administrator.
Okay, great. Thank you. That's a good suggestion. So it's on the nursing home website then. The one we had up earlier, is that what she's saying?
No, from NAB. Oh. Does anyone know what that acronym is?
She'll know. She's a nurse. I think she's got a nursing home administration, so she's.
Min, if you know what that acronym is.
What it stands for?
Or what it stands for.
Nursing administrative support.
What is it?
Nursing administrative support. Nursing home.
I thought it was big. Oh, okay.
HCB, I think.
Okay. Okay. That's a great tip. Thank you very much. Okay, so again, the strategy, where we're going to be in June, is not going to have all these things fleshed out. It's going to have the concept in, and then it's our job going forward to develop it, to bounce it off the advisory committee, to gather groups of people who have expertise to help us sort of develop and refine these things. But we're going to get the concepts into the strategy and then work through all the details as we implement. Okay? So I agree that we need to be cautious about it, because what we don't want is to have it characterize a center negatively or positively when that's not warranted. So what does that threshold mean? Right. But 100%, wow, that's impressive. Okay, so person-centered care. Okay, we only have one thing here, but we think it's a pretty good one. There's something else that talks about person-centered elsewhere. Establish core person-centered care practices and identify centers that implement, so the measure being they implement the core practices, and that would be a medium term. So again, what we were thinking here, something very broad, is to say that there are minimal ways that providers can meet the new federal requirements and that we're going to be testing to when we do our monitoring. So are the centers, well, they're going to be filling out a new IPC that is going to focus them on providing certain required information. They're going to be signing off on participation agreements that are standardized, that validate that certain things have been done, or at least that check off that certain things have been done. But that, and then during our whole other track on our HCB settings requirements that we're going about validating now, because the feds are requiring us to, we're getting ready to get started with our provider self-assessment. We piloted our process, and we're going to be getting out there and doing our reviews based on the pilot feedback, which we're going to share in the pilot group. I'm going to get Diane because she participated. So we're also going to be validating certain tests on the HCB side on those rules, which include person-centered planning. But when it comes to the higher level of person-centered care and all of the things that go along with that, as yet are are evolving and that we're all sort of like getting acquainted with, there's much more to person-centered care than just this person-centered planning piece. And so what are those things? So if the ingredients are advanced level training of staff, implementing of some of the tools that we've seen around tracking what the participants' sort of needs are and responding to them, and whatever those tools are and processes are that the centers are implementing to make person-centered care work, our vision is that we would have the advisory group sort of developing that sort of core list of best practices, and then we would identify centers that are doing that and giving them sort of credit for giving them sort of the point for having done those person-centered best practices beyond the person-centered planning. Does that make sense? I wasn't very articulate about that, but yeah, it's pretty basic. Okay, we put that as a medium term, not because we think that is like easier than long-term, but because it's pretty imperative. So.
Because on the short term, we're implementing the HCB setting.
Yes, we are.
Requirements related to person-centered care. So we've started. And
we have started it, but again, meeting the minimum standards that are in the HCB settings for person-centered planning is a far cry from actually implementing full person-centered care. Okay.
Didn't you say, just wanted to mention that the new MLTSS regs require person-centered process, as they call it, to ensure that beneficiaries' medical and non-medical needs are met and the quality and independence of life. But so one thing, I just want to put this out that I think the CMS is starting to look at it more broadly as an integrating factor between the medical and the non-medical. Yeah. So just for CBAS programs to kind of factor that in.
Yeah. Yeah. Yes, they most definitely are. They're definitely pushing all the states, and the states are pushing back on some of the stuff. So there's a lot still being played out. But yeah, it's definitely where we're going.
I know we're going to get more into this in the IPC piece, but it's really that the federal waiver requirements state with the HCBS. It's the process of person-centered planning.
Right.
So it's not person-centered care, but how is the process of person-centered planning taking place?
And that's why this one right here, we called it out as person-centered care on this matrix, but it really overlaps with best practices. So what we're really talking about is that person-centered care as the big umbrella of which person-centered planning and processes are one component. Yes. So participant caregiver satisfaction, we've already touched on this. Develop, adopt standard CBAS participant caregiver satisfaction survey, and then identify and sort of note providers that are doing that. So I don't know if it would get to the quality metrics like CADS is trying to work towards, I think, which is sort of percentage of those return or what it would be, but even just having centers sort of incentivized to do participant and caregiver satisfaction surveys, and then have processes in place to be responsive to things identified. I think from our perspective, that would be a huge win. So that's what we were looking at there. Moving on. Moving on in the wrong direction. Okay, so we are at best practices. We're almost home, you guys. 15 minutes. Okay, so establish sanctioned screening tools for CBAS disciplines and populations served for centers to voluntarily adopt. Okay, so we don't have regulations or laws that specify that certain screening tools must be used in certain cases. But we think that there's an imperative to start moving toward more screening. Some centers don't do certain kinds of screening that we think are absolutely sort of minimum things that should be done, like cognitive impairment screening, screening for depression, fall risk. Most of the centers are doing fall risk screening tools now because we require a standard test, screening test be issued for reporting on the participant characteristics report, but we don't specify which one is to be used. So if we think that there's some value, again, as a ongoing advisory group and those all of us that get involved in implementing this, to establishing set screening tools or a menu of screening tools, and then identify the centers are using those, we think that there's a great value to that. All right? Medium term. That's a big one too. Develop user-friendly program requirement checklist. We already talked about that. Everybody loves that idea. Next one, identify centers that inform and assist participants with completing advanced directives. Okay, so we had that one down last time. It was like one of the few on this list that we felt like, yeah, it's good, and maybe we can sort of somehow sort of promote that, but we didn't schedule it on this list because 20 just seemed like so overwhelming. So
it could be folded into the training. I mean, couldn't it be folded into training?
I suppose it could. So as one of
like leadership, person-centered care, advanced directive,
right?
And you can check to see
forms in the chart
if they've been completed.
Could be folded.
Put it as a task for the social workers to work on whenever not necessarily as part of it, but as social workers.
Because I think right now there's in a lot of policies and procedures there's talk about advanced directives, but most of the social workers that I work with don't know how to do that.
Right.
So it'd be great to do do a training on what it is, and even be culturally sensitive, because some social workers don't want to talk about it because they don't think their participants want to talk about it. So
Right.
that in the cultural sensitivity as well.
I got it. Okay. What were you saying, Daisy? Sorry.
I'm just surprised that social workers would not know
Yeah.
about it.
Yeah, well,
Yeah.
that's, well,
Okay, that's why we're driving people towards greater levels of performance. Okay, so the next one up, identify centers with quality improvement systems in place. And again, this is, we didn't schedule this one either, and I think that it's a placeholder for now, the idea that we have centers that meet the minimum requirements by regs to have a utilization review committee in place. And some centers actually have a really good quality review that goes on at that point during that UR process. But there's minimal activities, I would just say, that we see going on around quality improvement at centers. And so I think that it's a worthy idea, but I think, again, it's something that wasn't entirely well fleshed out, and so we just put it on that's sort of in the idea bucket category. It's not scheduled this time. But, certainly centers that are engaged in, the centers that are working on the CADS quality initiative and end up doing testing with that, the CBHH project centers, it's like there's clearly more drive towards quality in those organizations, and how do we take a look at that measure? Yeah.
If you were able to somehow just throw that in with other measures, it's an incentive to programs to start doing it if it's going to show up publicly.
Right. Yeah, I mean, that's how all these things work, right?
Right, but I mean, I think there's some value because if it tends to be more on the punitive side, and I think that well, and I don't mean that the way it sounds, but what I was saying about consumer friendly in part is not to have programs look such that people are afraid to use them.
Right, sure.
Which is how I often feel when I'm looking at some of this stuff. And so, I think if there's an easy way to build in and to begin to identify, as we get these measures in place, identify centers that have completed their menu and are carrying these out, I think that's an incentive to programs to want to get on that list. So you don't have to add it back in, but it's just a thought.
Yeah, no, I hear you, and it may be simpler than we were thinking.
And this might even be something CADS can put on their website, the top 20 centers, or the centers that scored, this much and above.
Or even just, everybody who's making an effort and showing up to do all those measures, because often new programs are in a different place than long-term programs.
Sure.
But that's the opposite of the punitive, to give them and it also builds us up, with this number of centers in California, or these are the centers. Might encourage people to
get on the list, like Ann says. You want to be on that list and not on the poor performers list.
On the non-list.
Yeah, or on the non-list, exactly. Okay. Okay, noted. And then the last one is just a placeholder to acknowledge that that participant outcome measures that the CADS folks are working on, the NQF, all of those things are things that are important for participant outcomes, but this strategy is going to focus largely on the sort of provider quality initiatives and frankly the department's quality initiatives to work more collaboratively to help the providers and help manage care plans. But that participant outcomes is sort of the next piece that needs to roll up in here, but we don't have those yet. So we're not going to start looking at emergency department visits or diabetes care or anything like that at this point. But we're putting placeholders there. So that's the whole list. I surprisingly got through by the end of the conference. So, okay, so let's, any thoughts from anybody about anything? The timelines for things, this is a sort of 5-year snapshot of some things that focus our attention. Many of them are things that sort of are carryovers that we've already started to work on, like the IPC. Many of them are brand new. Some of them are, like I say, fairly easy gets because we already have the data, but it's a matter of figuring out how to shape it, like those therapy hours data, how to make that information make sense, and then share it and vet it and share it. But it's ambitious. I can't lie about that. When we were looking at it, we were trying to find ways to cut it down, and it just seemed like they were all such good ideas. Yeah, Diane.
I hate to add anything to it.
Oh, come on.
But it's standing out for me because we just had a conversation about exposure control and all the bugs that come along and that kind of thing. And so the way it's popping up for me is I'm not seeing anything really on this list that pulls things over from public health.
Right.
And it seems like that's critical. We're missing that in some ways right now because centers don't get as much of that information directly.
Right.
And we have to go out seeking that information.
Right. So on the list of the minimum training list, I should have said universal precautions because that's right on there too. So would that be what covers it there or no?
Well, I think emerging information from public health.
Emerging information.
Yeah, and when that comes through CDA, one of the things that it does is to help line things up between what we're doing with CDA and Department of Public Health.
So do you see it as part of that training then, or is it something different? Is it a different category?
No, it's not necessarily training. Sometimes it's information. I mean, information about, I mean, it might be training, but if there's an emerging threat, for instance, public health concern, that's not initially about training. It's about awareness raising, and then it may be about training. Gretchen?
Well, what I'm thinking about is in the case world, you have your quality program, and then you have your infection exposure control program, and there's certain things that trigger reports to the Department of Health. And you actually also have to track, what's going on in terms of infections and so forth in your center. And I don't know if you're thinking about it in that level of detail, or it actually becomes part of the critical incident and unusual occurrence reporting process.
Right, but how would they know to report things if they didn't even know it was an emerging threat?
Right, so it's sort of that cycle, and I wasn't necessarily thinking yet of reporting, but it's starting with the emerging information. So emerging information, right now we have Zika virus, showing up. That might not be as relevant immediately to us, and we've had conversations about participants who go out of the country. When they come back, what are protocols that we need to follow, things like that. And so there might not be one we target right now, but when I go to Department of Public Health website and start to comb through for information that isn't coming from any other source and isn't being directed to us, I see plenty that I think I need to go after. And if we had a better conduit for integrating that would be very
let me ask you this, and the plans too. Do you guys subscribe to all facility letters that the Department of Public Health publishes?
No.
Okay. So all facility letters are issued through electronic. They used to be issued to all licensed health facilities via snail mail, once upon a time. And so we used to keep binder after binder after binder of all the AFLs, just like we do all center letters, ACL, they do AFLs. And you have to get on the distribution list, and you get electronic transmissions of AFLs. We probably get one a week, right, Lynn? Something like that.
Yeah.
And not all of them are relevant, and some of them go to specific facility types. So it'll be, they're all called AFLs, and some of them are directed specifically to swing bed nursing facilities, and some of them go to to hospitals, and some of them go to all facilities, which means ADHCs. And honestly, I don't know how they figure out how they work the distribution. I don't think you subscribe just to
It's
ADHCs.
very difficult.
It's everybody. So everybody gets pretty much everything. So here's, on the education front, we can remind providers that they should be subscribing to AFLs and looking at them. I look at them, every one that comes down, and some of them actually, are relevant to our staff. We'll pull them off and we'll do a in-service training with our staff because there's something that affects the centers. Whether it's, and some of them are like, seasonal things like seasonal heat, and they'll have, information about cooling centers and strategies for keeping older people from being dehydrated or what have you, to there's a new virus in town. And these are the expectations for public health around how you're supposed to be dealing with it. So there's a lot of things that come out of public health that routinely are distributed, but I don't know how they publish that and make sure that everybody knows that they're supposed to get them. Because back in the day, it used to be as soon as you got a license, you were on the list and you got a physical mailing of an AFL.
Right, and without a better bridge, without a better set of connections between Public Health and CDA, it can be very difficult to discern, even when they put us on the list, whether it applies to us and whether they put us on the list because it applies to us. I spent hours recently.
You're not alone, Diane. We call them often and say, does this apply to ADHDs? And, it's oftentimes not known.
It might not be possible, but I just want to throw that out as something that I really think is critical
It's
to us as healthcare providers.
And truly, it is our job as the primary contact for CBAS that we should be doing a good job of reading those, and that we do occasionally point things out to people like, hey, this was transmitted, and we'll link to it and everything, but we should be able to be counted on to distribute anything that has relevance.
Well, let me ask, because this may be a little bit different, but do you all do you know if everyone's had TB screen, and do you, if somebody comes in with a really bad case of the flu, do you put your staff in protective guard and isolate them? I mean, or is that level of infection control something that CBAS worries about?
So Kate's raised her hand. Hi, Kate. Kate just came in for the next meeting.
Our county requires that all of our staff have, as healthcare providers, have flu shots. And so then our agency requires it of our staff. And if they don't, then they are required to use the protective care all day until March 1st or April 1st, from October to April. And that's the public health department in our county that,
Not necessarily your CBAS regs.
well, that is also our higher up, our affiliation.
Hey, I think, I actually think this might be a worthy training topic, because if you could end up with some kind of infectious situation and need to report it or need to isolate people, and staff should be prepared for that.
Yeah, and again, it's really timely because Katz is going to do that along with the CLIA waiver training.
Right.
Oh,
Diane, if I could, because we're on the home stretch here for this meeting, are you suggesting that we should add another domain that has something to do with communication, and that we try to measure center exchange of information with staff beyond training?
No, I'm suggesting that if CDA can maintain a good partnership with the Department of Public Health to evaluate things coming out of public health that relate to us, and communicate that to centers to the extent that that is possible, that would be very helpful.
Okay.
So that we ultimately, if we get the letter, we're trying to understand the letter, but we've also gotten something from CDA that has clarified it. And we can call you guys as well to say, did this really apply to us? And how did it,
Got it.
that
Okay.
way.
Yeah, we can do that. I mean, we already get them now, but again, we have some of the same problems, and many of them are just not related to us. If there were something really significant.
Yeah, you do it to a great extent, but I'm not seeing it on the list, and I'm thinking it's probably going to be needed more and more.
We would piggyback any major things on the case and send it out. So, yeah. Okay, but great suggestions. Okay, so I think that brings us just about to the end of this meeting. So let's review the last couple of items on our list. We are supposed to do the action items, Lynn, before we can have our lunch.
Yeah. Well, a lot of action will take place in terms of the discussion of this form. So we're going to integrate what's been discussed today into this form. We're going to post it. We're going to distribute it for feedback to everyone who is a work group member. So that will be done before the next meeting. We'll revise that medication or management checklist based on what was discussed today about how to dispose of expired medication. I'm trying to differentiate what, is we're going to.
Yeah, there's a whole bunch of things.
I'm not going to get into that.
So sorry.
And then we will just follow up about the CDA, the Department of Public Health communication. That's something I think we need to take care of.
All these letters.
Figure out how to improve that relationship and communication. So I think that's it.
I had another one that Gretchen had mentioned that CMS released the LTSS standards this week, so we want to take a look at those for person-centered care and critical incident reporting. And I think that's it. Everything else we embedded in our discussion about that work plan. Okay, so that's good for that. There's several things that obviously intersect with the IPC, and that's coming up this afternoon. If anybody wasn't planning on staying and you want to stay, you're welcome to stay for that. Otherwise, thank you all for being in the quality group. Next time is our last time. We're going to bring it home and get this thing done. So if you have any thoughts in between, we welcome you to send it to us. But we'll send you something to respond to in the meanwhile. And
forming the advisory group for people to think about.
Forming the advisory group. Yeah, we were supposed to be talking about that. And here's us talking about it. We're going to do it, and some of you have already sort of pre-volunteered by just nodding in approval today. So we'll be soliciting those more formal agreements as we go forward. So thanks a lot to everybody in the room. Lunches should be getting here. We're going to have a break for lunch, and then we're going to do the IPC this afternoon. Thanks for everybody on the phone who's jumping off, and we're going to start back up this afternoon. If you're joining us again, appreciate it, and we'll see you then.
At 1:30.
1:30. 1 hour, yes. Okay.